Hello, everyone. Welcome to OBHealthy, the Physicians Health Network. We're a group of Black physicians that are here for two basic reasons: to improve the health of people of African descent, number one, and number two, to encourage young Black males to go into medicine. All righty. There are primary goals, I should say. Understand that our webinar is every second Saturday at 1 o'clock. And you can tune in. You can just go to obhealthy.com and click on the physicians button, and you will enter the page that will allow you to come into the webinar. So please let family and friends know, church members know, because it takes a village. And we're about educating as far as health is concerned. Understand that also you can check out all of our past webinars. You can check out all of our past webinars on OB Healthy as well. Just scroll down to the bottom of the page and hit the YouTube symbol. And that symbol will allow you to go into all of our past webinars, our channel on YouTube. Please subscribe once you get there so that we can continue to bring this webinar to you. I'd like to thank OB Healthy for allowing us to use their platform so we can bring this, this education to you as well. The one thing that I would like to say, and I think this is the most important thing that I can say, is that please do not change any aspect of your medical care, no matter what we say as physicians, because only your doctor can appropriately take care of your medical problems. All righty. We will have other physicians joining as we go along. Everyone's making rounds this morning, and they'll come in as they have time. The one thing is, and I'm so excited that we were able to bring you a presentation about renal or kidney problems this time. And we're going to start off with that topic. Kidney problems are something that is it's major in the African American community. So we should talk about this and we should understand it. We should know many things, as many things as possible about our kidneys and how we can preserve them. And we have an expert today to talk about it, Dr. Simon. So we will be getting with him. First thing I'd like to do is the physicians that are here, I'd like to see if we could introduce ourselves. And Dr. Simon, on my screen, you're the first one. So can you introduce yourself?
Hi, everyone. Thank you, OBHealthy, and thank you, Dr. Omar Bey, for this invitation. I'm so honored and glad to be here to share with our people the kidney, what it does for us, what they are, how to recognize when they are diseased, and what we can do to keep them healthy. I'm Segun Simon. I practice nephrology, which is a kidney specialist at Beth Israel in Newark and other surrounding areas. Thank you.
All right, thank you. Dr. Atherley, please.
Good afternoon, everyone. My name is Trevor Atherley. I'm an interventional cardiologist. I practice predominantly at Newark Beth Israel Medical Center.
All righty. And Dr. Kendall Sprott.
Yes, I'm Kendall Sprott, board certified pediatrician. I'm now retired. I did 15 years of critical care in pediatrics and specialized in general pediatrics as well.
All right, thank you. And I'm Dr. Omar Bey, pulmonary critical care with a subspecialty in nutrition. And so glad to be here with our brothers. Dr. Simon, let's get going and let's talk about the kidney. Can you just explain just some basic stuff about the kidney, what it does, how it functions, and what it does for our bodies? Okay, just give us an idea of what we're talking about today.
All right, thank you, Dr. Bey. So first, I just want to say, I like to break down the talk in, under a few headlines just to make it simple and concise for our people. The kidneys, what are they? So there are two bean-shaped organs that are located, I'll say, around the midriff of the body, a little bit closer to the back. So if I could demonstrate to our viewers, if you're standing and you have your hands at your back, resting like that, you're probably placing your hands right around where your kidneys are located. And God has been so gracious to give us two of them because he probably knows why we will need those. It does a lot of good things for the body. I always like to challenge the cardiologist. Thank God Dr. Atali is here. And I will say that, oh, the kidneys are way more important than the heart. But that's just another discussion for another day. So the kidneys are there. We have two of them. They receive blood supply for the heart. And primarily, they keep us in check in various ways. They help us to excrete toxins. So you can imagine everything that we put into our mouth, be it food, medications, and all kinds of liquid that we drink. Not everything is good for the body. So what happens is once metabolism takes place, the body takes the good stuff, and majority of the bad stuff that we call toxins gets excreted primarily through the kidney. So this is what the kidney does. It helps us to urinate, and so that way we're not swollen. So essentially, whatever we drink, the quantity of fluid that we put in, we get them out through the urine primarily. And it keeps our acid base in balance. So that way our body stays in a very good environment for all the other cells to function better. And it helps us to control our blood pressure because of some hormones that it releases or does not release when it's not appropriate. And so there's a whole lot of, it helps us to regulate vitamin D, which is also very important in maintaining our bone health. So today we're going to be talking about each of this topic in a little more detail. And when we understand what the kidney does normally, then we begin to appreciate when it's not doing what it's supposed to do. It's also going to show how we recognize some of those signs and symptoms. Thank you, Dr. Bay.
Yeah, definitely. You know, there was one thing you were saying about the fluid balance. I know that we as, people of African descent, salt is something that creates havoc with our bodies. It helps us retain fluid. In retaining that fluid, our blood pressure goes up, Dr. Athley, and that overall affects so many organs. And increased blood pressure definitely affects the heart, but it affects the kidneys as well. Tell me about some of the diseases that you think about when you are with a patient that would, lead you to think that they may have a possibility of developing kidney problems.
Yes, so just like we said, some of those functions that it does, that's how we'll be able to recognize when the kidney is not working properly. So you can imagine if you're not able to urinate adequately every day, the amount of fluid you put in, you will get swollen. And this swelling can be, around your eyelids, we call it puffy face. It could begin around your legs and then begins to go up. Interestingly, heart problems can cause this as well, but the heart and the kidneys tend to work together, and whoever is swollen could either have a heart or a kidney problem. So swelling is one of the keys, besides decrease in urination. And then also generally you can see obvious abnormalities, like you see blood in your urine when you pee. That is a red flag and not normal and should be checked out. If you pee and it gets too foamy, like you're peeing in the toilet and there's too much bubbles, almost like a soap. Some of this could be a sign of too much protein in your urine, and definitely should be checked out for kidney disease. When it comes to blood pressure, the kidney plays an essential role. If you have high blood pressure and you've been controlled on medication, suddenly your doctors are having to increase the dose of your medicine or add more medications. It could really be a sign that your kidneys may be struggling, because like I said, the kidney plays an important role, especially for African American, and Dr. Bay just touched on that. I guess traditionally or in nature, from where we come from, it was said back in the days that because of the lack of access to water, our kidneys somehow had to preserve life. And so it had this tremendous ability to retain salt and water, which was a way of keeping that body hydrated until the people were able to get to water. And so even when people migrated from those climate into the temperate world here, the kidney still retains this innate capacity because we've tested that in the lab over and over. And that is one of the reasons why the water pill, if you're familiar with it, there are some blood pressure medications that they call the water pill, hydrochlorothiazide, and they are said to be way more effective in controlling blood pressure in African Americans because our high blood pressure is somehow tied to excessive sodium and water retention. And so the kidney plays a big part in that. Then some very non-specific signs like nausea, vomiting, poor appetite are also signs of kidney disease, especially if it is severe. And this is really a sign of the body saying, hey, we're not going to be able to excrete any of the waste that you generate. So don't bring anything in here. So, and that's why you just get nauseous, or you're not able to eat, people start to lose weight, and you start to accumulate a lot of toxins in the body. And just this general feeling of being unwell could be a really big sign of kidney disease.
Excellent.
Let me chip in a little bit if I can.
Mhm.
First of all, it's great
Yes,
to have Dr. Seibel with us, an old friend of mine. And to challenge you a little bit, because you did mention about the heart versus the kidney, just to mention in terms of the relative importance, that I would rather do without my kidneys for 10 minutes than do without my heart functioning for 10 minutes. And I'm sure all of us would. But anyway, the concern about fluid, excess fluid in the body is one that we both share, because many times patients may present with the signs and symptoms of excess fluid. And you and I may both be challenged to determine the cause of this, to determine the relative importance of the heart versus the kidney, and to decide how we investigate these and how we treat them. I appreciate your mentioning the genetic predisposition that we have for fluid retention. And our geneticist is not at the moment with us on one of his favorite topics has been, I'm sure, if you joined us later on, or one of the favorite topics has been that our involuntary travel from Africa to these countries in the West, it was partially facilitated by our ability to hold on to salt when we were in the holds of those ships coming over. And so those who survived best had the ability and genetic predisposition to hold on to the salt. While that was good at that time, it now does not serve us as well in these modern times. So maybe we can talk a little bit about some of the signs and symptoms of too much fluid in the body, whether it's from your section or from mine, and what we can do about it. From my viewpoint, for example, patients who have too much fluid may often have this accumulated in locations that may be fairly obvious by way of signs and symptoms, or maybe more subtle. Many times that fluid excess is, as you mentioned, face and other features, and especially the lower extremities, you may see excessive fluid, what we call edema in these areas. And we are faced with the challenge as to the etiology or the cause of this. Sometimes the location of the excess fluid is a little more subtle. Patients may be concerned about shortness of breath. Shortness of breath when laying flat, shortness of breath when up and active and moving around, etc. Again, we do a variety of tests to determine the cause of these and to tackle them together, or whichever area is more important, we tackle that primarily. From my viewpoint, for example, many of my patients who have too much volume, too much fluid in the body will present with fluid in the lungs. And the shortness of breath is paramount and a major aspect of their presentation. We have very simple tools that we use over and above the easy access with the stethoscope and talking to the patient and listening to the patient's lungs, where we can hear the crackles and the sounds that suggest that there may be excess fluid there. Chest x-rays are often very helpful to us. Now, again, the chest X-ray, while showing fluid on the lungs, may not easily distinguish the heart etiology or cause from the kidney cause. If we see abnormalities of the heart specifically on those X-rays, it may lead us more in that direction than we do other more sophisticated tests. But the simple chest X-ray is one of the things that may show us volume overload. I'm not sure how that helps you, what investigations you go first when you're looking at the potential for the kidney disease. But let me ask, if I may, what sort of tests you might recommend or suggest that the regular patient may have to determine if the kidneys are not functioning well and if they're the reason for the excess fluid that's on board? What sort of tests would you recommend?
Trevor, before he answers, could I just add a little bit more? Because I think that's important.
Right, yeah.
But you know, my starting point always is what's normal and why is it normal? And one of the aspects of what's normal is, you know, if you think about it, is the volume of fluid and cells that are within the blood vessels. And that's an important component of what makes up blood pressure, is the volume of blood within the blood vessels. And one of the things that happens is that you have fluid within the blood vessels, but you have fluid that's sort of around the cells. And the fluid that's around the cells, not within the cells, is fairly constant. And what determines the volume of fluid outside of the cells really is the amount of sodium in the body. And the sodium has a certain amount of water. But if you think about what's going on, is there's this, I call it a dynamic equilibrium. There's a certain amount of fluid that's being produced that leaves the cells, and the same volume of fluid that leaves the cells returns to the cells. And that's how the volume within the blood vessels stays normal and the volume surrounding the cells stay normal. Now, one of the components that is important that maintains the volume of fluid within the blood vessels is a protein called albumin. That albumin is something that is sort of made by the liver, but it's also an important component of what you ingest, and the proteins that you ingest contain a substance called nitrogen. And the only way that our body gets rid of nitrogen when you ingest protein, the foods that you can ingest are proteins, carbohydrates, and fats. The fats and the carbohydrates, when they get metabolized, they form water and CO2. And that CO2 can be blown off, carbon dioxide via the lungs, and the water you lose normally through, the largest portion is via the kidneys, but some of it is lost through the skin, and some of the water is lost through when you're breathing. But that albumin is an important component, that if the albumin within the blood vessels becomes low, then there will be a less return of the water that comes out of the blood vessels returning to the blood vessels. And what happens is that the volume of fluid within the blood vessels is less than it should be, and the kidneys try and restore that volume by retaining sodium and water. The problem is that sodium and water that gets retained can't get into the blood vessels because of the lack of protein, albumin. And that albumin can be low because the body's not making it because of the liver, which is responsible for making it, or it may be lost through certain kidney diseases in the urine. And if it's lost and the volume of albumin within the blood goes lower, then the patient will start to retain sodium, trying to restore volume to the blood vessels, and it doesn't happen. And so the patient starts to retain the sodium that they normally would get rid of. Remember, under normal circumstances, all the sodium that you take in, your body gets rid of. And as long as the balance between what you're taking in sodium and what you're excreting, especially via the kidneys in sodium, it maintains a balance. But once you start to have the kidneys believe that the volume within the blood vessels is less, then it tries to restore that volume. And since it can't, you just gain more and more sodium. That sodium stays outside of the cells, and that increase in the fluid outside of the cells is called edema, and that's why you start to have swelling.
Mhm.
Now, that's one of the ways that you can. And if the heart isn't working, you can have edema or buildup of fluid behind that, which is another issue. But I think that it's important to understand that the kidney, although Trevor, you said that, you can't live but for a couple of minutes without the heart beating, the kidney does a lot more in terms of how it functions and what it does than the heart, which is primarily, Dr. Simon would say, is a pump that's responsible for pumping blood to the brains, to the liver, and to the kidney.
All right. That was excellent. But let me just preface one thing that you said, Dr. Sprott, and just very simply, so that I think our audience can understand. Our water follows the salt, and if the salt is more in the tissues, then you're going to get more water flowing into the tissues, and you'll get swollen. If there's more salt in the vessels, then the water is going to come, the water in our blood is going to come into the vessels, and then it's going to connect with the kidneys, and then it's excreted out. And that's a simple way of thinking about it.
There's another aspect to that, though, and that is just water itself.
Right.
The water itself is important, and the water that you take in also has to equal the water that you excrete.
Right.
If you don't do that, and the way that that's regulated is by a part of the brain that's responsible for if you have too much water and your salt or your sodium concentration starts to go down, it allows the kidney, says, get rid of the excess water, and it does. If you don't have access to water and your salt concentration goes up, it says, hold on to water.
Hold on.
That water is retained, and it causes your sodium concentration to fall.
Right.
So the kidney is the mechanism by which you balance the concentration of the salts that are within your blood and the amount of water that's in your body.
Excellent. I know, Dr. Simon, we're going to hold on because we're going to get to you. But and what I'd like to do is, several of our physicians have come in. Let me do this. Let them introduce ourselves, and then what we're going to do, Patrick, I see you have your hand up, and we'll let you ask our question, and then we're going to get back to Dr. Simon, who has all the answers to what we've been talking about. Okay, Patrick, can you start us off? Can you introduce yourself?
Yes, I'm Dr. Anderson, Patrick Anderson. I'm a G1 oncologist. I work in the RWJ Barnabas system with just about everyone on the panel, and I've been trained and nurtured by several people on this panel, and I'm honored to be here.
All right, thank you. Dr. Daniels, it's good seeing you, brother. Can you introduce yourself?
It's been a while. I miss you guys. Yeah, my name's Lawrence Daniels. I'm a pediatric and adult neurosurgeon and the medical director of pediatric neurosurgery at Jersey Shore University Medical Center.
Excellent. Dr. Aluya, please.
Yeah, good afternoon, everybody. It's a pleasure to be here once again. I'm internal.
Oh, we lost Dr. Aluya. All right, I'm sure he'll sign back on and he'll introduce himself. Dr. Court, you're still on mute. Can you introduce yourself?
Good afternoon, Dr. James Court. My practice is located in East Orange, New Jersey. My specialty is internal medicine.
Excellent. Thank you very much. Dr. Anderson, yes, it's your turn.
Yeah, the comment I wanted to make is that the kidney is this interesting organ that if you parallel as a basketball team, it's like the point guard. It tells kind of through the fluid and electrolytes. Electrolytes is the salt in your body, kind of directs the brain, the heart, and even the molecular system that includes organs like the thyroid, which manages the chemical reactions that happens intracellularly, how to function. And one of the way I look at the kidney is, as Dr. Sprott so eloquently explained, is look at the different compartments in the body that it influences all at once. So when we talk about fluid intake, is not just what you ingest, but the fluid created through some of the chemical reactions. When you talk about salt production, it's not just the salt you ingest, but the the salt and the electrolytes that results because of some of these chemical reactions. And then the physical component that always intrigued me is the interaction and the communication between the heart and the kidney as it relates to the workload that the heart sees every time it contracts. And this directly relates to the kidney and how much fluid is on board. And when we talk about on board, we talk about, as Dr. Sprott said, what's in the intracellular space, the space between the cells, and what's in the intravascular space, the space in the blood vessels. What's interesting about the space in the blood vessels to me, as Dr. Sprott talks about the salt, the albumin, is also the weight of the other components of fluids within the vessels, like the blood. So even anemia, the amount of red cells within the blood vessels influence how fluid exchanges across these membranes that separates the intravascular, which is the vessel, the space in the vessels, and the interstitial, the space between the cells. So the kidney is, I'm not so sure how I would get involved in the fight between the importance between the kidney and the heart, but at the end of the day, I'd rather not live without any of them.
I hear you. Well, Dr. Simon, Dr.
Yes,
Arrow
sir.
had asked about tests that you would do to determine whether there is truly a problem with a patient's kidneys. When a patient comes into your office, I know that you've been doing this a long time, and it's like, rote for you, but give us some understanding about the tests that you do to determine some of the kidney problems.
Right. Thank you, Dr. Bay. I am so glad to hear everyone speak about the kidney in this manner. And Dr. Anderson, I like that point guard analogy that you give to the kidney, because that's essentially what it does. Before I go into the testing, and just based on what everyone has said, I can throw it out there that every swelling that someone has, the kidney somehow has a role to play in it. Even if it is primarily a heart problem, somehow the kidney has a role to play in the swelling, because whatever comes into you must go out to keep you euvolemic. And who ensures this happens?
Euvolemic?
To
Can you
keep
explain
you
that? Yeah,
not
it's a little,
to keep
like,
you in a dry state, so you're not swollen.
Mhm.
So if you drink, I'll give numbers. If you drink 2 liters of fluid in a day, you are going to pee out 2 liters of fluid in a day. Now, there are some semantics behind this, and Dr. Sproul was talking about, like, when you metabolize carbohydrate, it ends to CO2 and water. You blow off the CO2, and the water somehow you get rid of it. So there are some obligatory water intake, and those are usually buffered off by our obligatory water loss as well. So our obligatory water intake, for instance, are the amount of water we generate from metabolism, like carbohydrate metabolism, water that comes with food that we drink, the minimum amount required, which is about 500 mils a day, and all of that. But then our obligatory water loss would be water in stool, which is minimal, then water through the skin, and water through our breathing system. All of these sort of offset each other. So now that leaves the elective fluid intake must be equal to the elective fluid loss. So if anyone has swelling, somehow the kidney is not doing what it's supposed to do, either because it's receiving a sensor to say, hey, there's something wrong in the compartments of the body, the intravascular space, that is the fluid around the cell within the vessels. At every point in time, the body is able to assess the integrity of the main vessels in the body, and they send signal to the brain as well as to the kidney to say, hey, we have enough fluid, or hey, we don't have enough fluid. And then the kidney will act appropriately. If the kidney gets a signal that this body does not have enough fluid, the kidney will begin to hold on to salt and water to keep it in balance. If the kidney gets a signal that we're having too much fluid, the kidney is supposed to let out water and sodium so that we achieve the balance we need to. So each time anyone is swollen, no matter what the cause is, the kidney is playing a central role in to ensure that that swelling is ongoing.
Mhm.
So now we appreciate the heart because yes, it's a pump. For the kidney to make the urine, the heart has to pump the blood to the kidney. So, okay, if the heart is not able to pump it down to the kidney because it's failing, then the kidney does not get a signal that the body is in a good volume status. And then the kidney begins to say, oh, I think this body needs help. We need to hold on to more salt and water because I'm not getting good signals here. And so it starts to retain more sodium, more water, and then the swelling continues. Now, coming back to your question, which is what tests can we do to know if the swelling is from the heart, or generally to check for kidney function, if the kidney is diseased or not? There are 3 categories of tests that we can do. The most obvious and easy one is what we call a blood chemistry. And the chemistry will assess certain electrolytes and certain chemicals in the body. It will assess your nitrogen, your creatinine, which is sort of a muscle protein that over the time has been used to be able to assess what the kidney function is like. And it will check your sodium and your calcium and chloride and all of that. So this test is very simple, under $10. Because I tell people in my office, and they say, oh, I don't have insurance, oh, so I can't check. That's why I haven't checked my kidney. I say, well, if you eat every day, then you have $10 to check what your kidney looks like. When they give you that chemistry, it essentially just gives you a snapshot of what your kidney function is. And I always tell my patients, ask your doctor what exactly my number is. Don't just take, oh, your kidneys are fine, so see you in 3 months. No, what exactly is my kidney function? This test can tell you exactly what the number is. Are you 60%? Are you 40? Are you 30? And this number is your GFR, which is your glomerular filtration rate. I won't go too much into that, just to keep it simplified. But the number essentially translates to the percentage of your kidney function. And a normal kidney function should be 90% and above. So if you're under 90, then you've got some kidney issues going on. Now, based on how severe this number is, we can further classify into stages how severe your kidney disease is. That's the first category. The second category would be to look at your urine. So we call it urinalysis. That is even much cheaper than the blood test I've just explained. And when we look at the urine, which I like to call a liquid renal biopsy, it basically can give us a whole lot of information as to what the kidney is doing. Because remember, the urine is a product that comes from the kidney. So do we have protein in there that shouldn't be there? Do we have blood in the urine that shouldn't be? And what are the compositions of those chemicals we just talked about? How much sodium is in there? If you're swollen and you have a lot of fluid in you, and the kidney is letting out urine that has a sodium concentration of 5 or less than 10, then that kidney is the problem. So when you look at the amount of electrolyte the kidney is letting out, when your kidney is happy, if you're well hydrated, the kidney should be able to, or if you're getting swollen, the kidney should be able to let out more fluid and more sodium, so you get rid of that swelling. But if you're swollen and you look at the urine sodium, for instance, and it's so low, that tells you that kidney is playing a primary role in that swelling, because for some other reason, it's choosing to hold on to sodium and water while the body is already swollen. And that was what I was trying to explain. So urinalysis tells us a whole lot about what could be going on with the kidney. And now the third category, just to cut this short, will be a kidney ultrasound, which just helps you to look at the anatomy, meaning the physical characteristics of your kidney, how big they are, how small, are there stones, are there tumors, Is it abnormally shaped? Is it present where it's supposed to be? That's the location. And are there a lot of cysts in it? So there are a lot of information we can actually get also from doing a kidney ultrasound. So the three tests are kidney ultrasound, a urinalysis, and a blood chemistry.
Just to add an important component, and was touched on, is you want to look on that blood chemistry, the total protein and albumin that's there, and you want to see whether or not there's albumin in the urine or not. Because if the total protein is low, primarily because of the albumin, then the question is whether or not the albumin is not being made or it's lost. And remember, the important function of the kidney, one of the major of how it regulates, is it acts as a filter, which means that there's certain things that are being filtered from the blood. And the one thing that usually is not filtered by the kidney is albumin. But if somehow or another albumin is being lost through the kidney, it means that the volume of fluid within the blood vessels is low. And then the kidney is going to retain sodium and water to try and restore it. But again, it can't. And the other thing that Patrick spoke about was severe anemia. You know, people that have chronic anemia like sickle cell, they have a smaller volume of red blood cells in their vessels, but the blood volume within the vessels is normal. And the reason that it's normal is that the body has retained sodium and water to keep the volume in the blood vessels normal, even though the number of red blood cells or the red blood cell volume is less. And what happens is, because that volume is less, what the heart does in response to that is, because it's got to deliver a certain amount of oxygen to the tissue, is that the heart starts to dilate. And so with each time it pumps, it's pumping a larger volume of blood. But again, the volume of blood is normal, but the number of red blood cells is less, which means that the amount of fluid within those blood vessels is increased. That becomes very, very important, because in people that have sickle cell disease that might need to get a transfusion, remember that the blood volume is normal. So that excess blood that might be infused could cause the heart to fail. So when people that have chronic anemia need to be transfused, they need to be transfused very, very carefully. They can't take the same amount of blood that someone has lost blood via hemorrhage can take. You can give them lots of fluid to try and restore the volume. But because the volume of blood in the vessels is normal with chronic anemia, you need to give it time for the kidney to push out that fluid in order to balance out the difference between the red blood cells that are being added and the fluid that needs to be gotten rid of.
Very good. Yeah. All righty. Any other questions to because I have a few.
Right.
Oh, excuse me. Oh, goodness gracious, we popped up there. Dr. Aluya, we'll go with you, and then Dr. Anderson.
Yes, sorry, good afternoon. We commonly say the devil is a liar. I was just trying to introduce myself, but the internet just went off. So my name again, humbly, is Nelson Aluya. I'm a medicine pediatrics trained, assistant professor at New Jersey Medical School, but more importantly, and the role I play now, the chief medical officer of the great Newark Community Health Center, which is a federal health qualified center. What we do is we provide healthcare at the primary level for the community, especially those indigent community of patients who are uninsured. So we are at the forefront of healthcare as it may be, and it's funded by the federal government, which is holding us to task to ensure that we provide the care that we need to provide for our community, and understanding that the community we serve disproportionately affected by healthcare and healthcare inequalities. So that's what we do, and that's what I do. And often enough, when I talk, I will talk on the population health standards and on areas where the physiology, the funding, the money translates into the physical manifestation of what the disease look like for our people. And that's where I come from. So that's what you're going to hear me talk about.
Excellent, excellent. All right, I'm going to come back to you in a minute, Dr. Aluya, because we're going to talk about diabetes and why that is a major focus for kidney problems. But Dr. Anderson, please, you have your hand up. You're on mute, Patrick.
Yes, so yeah, I was going to actually ask a question that you kind of touched on as to Dr. Simon just talk about some of the common diseases that directly affects kidney function.
Yeah, Dr. Simon, can you chime in on that?
Yes, thank you, Dr. Anderson. So worldwide, as well as in the United States, and surprisingly also, even in developing country, the leading cause of kidney disease today remains diabetes. And I always say this, if you've got diabetes, you are going to have kidney disease, supposing you live long enough. And this is regardless of how well controlled you have the diabetes or not. And this is important. And the reason is because the interplay between diabetes and what it does to the kidney, it's just almost a given that over time, your kidneys will slow down. I like to point it this way. It's like when you have diabetes, your kidney starts to run. And I always say, when do you get tired faster? When you're running or when you're walking? And obviously, the answer is when you're running. So once diabetes kicks in, our major job as nephrologists is just to try to slow the kidney down as much as possible so it doesn't run. Because if you leave it running, even though the test does say the creatinine is normal or your GFR is normal, but understand that the kidneys are running. Down the road in 10, 15, 20 years, they're gonna begin to tire, and then you see the GFR starts to fall. So diabetes is overwhelmingly the leading cause. The second to that will be high blood pressure. So now you can understand the high blood pressure does similar things to the kidney, but a little bit in a different way. It can impact blood supply to the kidney because the vessels that supply the kidney, if they've been under tremendous high blood pressure for years, they begin to thicken up and become more muscular. And if you think about plumbing, it's now a pipe, and your pipe is sort of clogging up. And now you're having to pump at a higher pressure to try to deliver the same amount of fluid to where it's going to get to the kidney. And so the heart has to pump higher, and then your pressure is higher. And even with all this, you still get less and less blood supply to the kidney. And then the kidney begins to starve. Ischemia, we call that, lack of supply, basically. So now if you've got diabetes and then you've got high blood pressure, so it's sort of like a double whammy. And as you will recognize, these two conditions are really endemic among our community. And we need to really, really educate people more about those so they can begin to pay attention. Now, the fact that I said you will have kidney disease if you have diabetes, regardless of if you control it or not, does not mean you shouldn't control it. Because if you don't control the diabetes and the high blood pressure, then you're really, really asking for it much earlier on. The third leading cause will be like inflammation within the kidneys, and those inflammations can fall into different categories. It could be genetics. We call them glomerulonephritis. It could be drug-induced. It could be genetic. It could come as a result of other health conditions that people have. So yes, those are the three leading causes of kidney disease worldwide, and it applies to our community as well. Thank you.
Dr. Atherley, excuse me, I'm sorry, Dr. Court you have your hand up, Dr. Court.
Yes, sir.
Thanks for being patient.
Okay. Dr. Simon,
Yes, sir.
frequently I'm faced with this problem or question from patients. I'm not taking metformin because it causes kidney failure. Can you explain to the world?
Yes. So this is one question I would say I get asked probably the most in my office.
Dr.
And-
Simon, before you start, can you
sir.
tell me why would somebody take metformin? What is metformin? So we'll know what the relationship you're talking about.
So metformin is one of the medications that is used to treat diabetes. It's one
Right.
of probably the oldest medications around. It's highly effective and usually a good starting point for people with diabetes. And people have this misconception that it causes kidney damage. The answer is in two parts. Generally, it will be a no. However, we do know that any medication worldwide has the capacity to cause a reaction within the kidney, what we call just like an allergic reaction. So it's like you saying, what can you be allergic to? Sometimes nobody knows until you try. So some people could be allergic to metformin, and that allergy can come in the form of a reaction within the kidney. Now, this will usually happen when you're exposed to metformin around the first time. So, but outside of that, metformin does not cause damage to the kidney. What we tell people is, if you've got kidney condition already beyond a certain severity, if you do take metformin, then you're at risk of a condition called lactic acidosis. So that's your body will have a tremendous ability to retain acid. That's because metformin can mess with how acid.
Dr. Simon, you turned on your mute. I'm sorry, by accident, you turned on your mute. There you go.
I'm sorry, yeah, I got a call came in, that's why I'm sorry. So metformin has the ability to affect how the cells handle acid production and destruction, actually within the mitochondria. So even when metformin was made, there was another drug, sister drug called fenformin. Back in the days, that has been withdrawn from the market a long time ago. That's because this phenomenon was actually associated more with that fenformin, so it led to its withdrawal from the market. Metformin is the sister or brother drug who is much better, but still has the ability to do that when your kidney function. Generally, we say if you're below 30%. So if your GFR is below 30%, avoid metformin because of this risk. But it's not that the metformin will cause the damage. It's just that when your kidney is slow, you can develop this condition if you're taking metformin. So I hope it is clear to everyone listening and watching that, because I see people come and they have a GFR of 60, 70%. And when they say, my doctor said I need metformin, but people told me, oh, it's gonna damage my kidney. I said, no, not quite like that. So Dr. Court, I hope this is clear. Thank you.
I hear that all the time, doctor. I'm on the same page as you are, except for the allergic reaction, which might occur when you take it for the first time.
Right. All righty. Dr. Sprott, your hand is up.
Yeah, he mentioned glomerulonephritis and the inflammation associated with that part of the kidney that serves as the filter. No, in pediatrics, I occasionally treated children that had glomerulonephritis after they had an infection with strep. And I know, Dr. Atherley, that some kids that have infections with strep can develop problems with their valves. Could you tell me a little bit about what happens when someone might have an infection from a strep infection and then develop this damage to the kidneys?
Yes. So the kidney has several components, it has several parts. Like Dr. Sprout rightly mentioned, it is a filtering system. So, but it serves as a filter, but for it to be able to filter, there are several layers that the blood flows through before it gets filtered. So, and those organs or those layers have different composition of protein and other chemicals to form that layer that allows certain things to pass through and not some other things to pass through. So now when people have infection with certain organisms, the body reacts to this infection in different ways. We know about antibody response to infections. Antibodies are sort of like soldiers that the body makes when there's an infection. And then it retains some of those antibodies as a memory cell. So the next time it comes, the body is ready to fight it again. And now sometimes when the body responds with those soldiers or those antibodies to a certain infection, the response can be exuberant. And then some of those soldiers, which are the antibodies, also eventually, because they travel around the whole system, scavenging for that infection, trying to get rid of it, but ultimately they need to be gotten rid of themselves. And sometimes after taking care of the infection, they go to different parts of the body and they cause sort of an abnormal reaction around that. Some of these mechanism is idiosyncratic. Well, it happens in some people, but not in others. It's not essentially clear why some people will develop it and not others. This infection is not restricted to just throat infection. People who have skin infections can also have the same. And partly because the protein within the filtering system in the kidney share a lot of similar characteristics with some of the proteins that we have on our skin as well, along what we call the basement membrane. That's just a layer, one of the layers along this filter mechanism. So it's more really of a reaction that does happen abnormally within the kidney. And then this triggers a host of other immune response and eventually leads to kidney damage.
Excellent. Dr. Aluya, you're on mute, but you have a question. You're still on mute, Dr. Aluya.
Yes, sorry. It was more not a question per se, but more a little bit of a contribution. And I like the way Dr. Simon put to rest. I hope it has finally put to rest the issue of metformin causing kidney disease. It's something I deal with on a daily basis as well when I see patients and on all the other things that people talk about. Metformin is still standard, ADA, #1 medicine for treating diabetes, bar none, still the #1. However, technology has evolved all through. Metformin came out way back in the 1950s. I think 53 or something has been around. But it's getting the bad rap from its cousin brother, fenformin, like Dr. Simon talked about. And that was typically related to the lactic acidosis that it formed. However, like I always ask, even professional, show me one episode of lactic acidosis from metformin. They've never seen one. So it's still the #1 drug of choice. It's still very safe. As a matter of fact, I'm a big proponent for metformin because it's cheap and some people give it freely. And I think as diabetes and the #1 cause of kidney failure in our community and everywhere in the world begin to match on in our community and the homes where we come from. When I say the homes we come from, the continent where we come from, Africa, I think metformin should be made free in its entirety. A lot of the medications that people are building out from, the GLP-1s, the GPP2s, those are the new medications, the technology that are coming out. They're actually coming out from the function of how metformin works. Because metformin works in the brain, it works in the GI tract, it works in the pancreas, on all of this. So they take a little bit out of it and push out there. So in order for them to push the drug that's expensive, that is new, they spend a whole lot of money on, a lot of people somewhere are giving metformin a bad rap. So it's still, as a matter of fact, the biggest complaint that people tend to complain about metformin, oh doc, you make me go to the bathroom. Yeah, you know, and I say sometimes it makes you go to the bathroom, you lose some weight, which some of us need anyways. But that's, you know, another story. With regards to the glomerulonephritis that was also talked about, we know that bugs or infections or bacteria don't want to die, and they adjust and adapt, and they adapt to the environment where they live, and in the process, because they rapidly grow, the lifespan is really quick. So they also, you know, Dr. Simon talked about it. They mimic the environment where they live. So they take up the DNA code where they live and mimic the environment. And in doing that, they kind of find a way of securing themselves. They do that in the heart, they do that in the kidney, so that when the body produces antibodies to kill them, it thinks that is the body. So it doesn't want to kill them. So, but in the process, the body don't care anyways, so it tries to kill them. And they do that in the heart, and they eat up the valves where they hide behind. And they do them in the nephrons where they hide as well. So that's one of the ways where, you know, how glomerulonephritis infections mimic basement cells so that they protect and preserve themselves. So for other things that are coming, it's translating what kidney disease is in our community. How is it that Black people are disproportionately affected when it comes to kidney disease? For some of you who know me, I'd like to give a global perspective and I bring it down home. Globally, maybe Dr. Simon had said something about that and I joined in a little late. Globally, I think we have what, almost 8 billion people living on Earth right now. And 10%, about 10% of the global population has chronic kidney disease. And if you put that in numbers, that's almost translated to 840 something million people with chronic kidney disease. That's a lot of people, almost 1 billion. Now, if you bring that here to the United States, how does that translate? Here, I think 15% of the individual who live here in the United States have chronic kidney disease, 15%. And that's translated to about 37 million people, which is a lot as well. Now, if you break that down, there's chronic kidney disease and those who have end-stage kidney disease, meaning they end up on dialysis. Now, with that 15% that have chronic kidney disease, it is said that 9 out of 10 of people who have chronic disease, kidney disease, don't even know that they have chronic kidney disease. And that's bad. I was talking to a young gentleman earlier in the week who I had to tell he has chronic kidney disease. If you know, Dr. Simon had talked about the stages, stage 1, stage 2, stage 3, stage 4. By the time you get to stage 4, that's severe chronic kidney disease. Now, stage 3, they have stage 3A, 3B, which is moderate, severe. But by the time you get to stage 4, which is severe, and then stage 5, which is end stage, you get onto kidneys, to get on dialysis. Now, a lot of people don't even know they have stages where that can put them into dialysis. And that is a big issue in our community. And it comes down to our community especially, where that in this country, 1 out of every 3 person who has chronic kidney disease is Black. Now, the question is why? And that's why we're having a conversation like this, so that we will put information out there so that we know what those information are, how to protect ourselves, how to preserve our kidney, and how to take steps to mitigate those things that put us in situations where we have chronic kidney disease or being on dialysis. Because I always tell people this, dialysis is a disease in itself because you hooked up to a machine 3 times a week. And if you think, oh, I can't take my blood pressure medicine, or I can't take my diabetes medicine. If you get on dialysis, guess what? They'll put 3 or 4 new medications on top of that. And as well, you can't even work because 3 times a week, you hook up 6 hours a day on dialysis. And that's bad. And that's why, like I always say this, when you hear good news, you listen with both ears. People who are on dialysis in this country, we as Black people constitute about 16, well, some people say 15, 16% of the population in this country. But 34% of us are on dialysis. The question is why? And I'm sure Dr. Simon will talk about that because recently we begin to know that there's a gene that's coding why we have worse outcomes from diseases that result in kidney disease. APOL1 gene. What is that? What do we know about APOL1 gene? How do we identify those who amongst us have APOL1 gene? Because it's inheritable. And we pass on from generations to generations. And what ending up at dialysis, Dr. Simon said that once you're on dialysis, it's like once you have diabetes, it's like your kidney on the run. And eventually you end up with chronic kidney disease. Somewhat he said that. But one of the things that had really frustrated me as an individual was that I have seen some patients who are managed with diabetes. And I have over the time controlled the diabetes, but I slowly watched their kidneys fail. I never knew the reason why. But now I know that there's a genetic component that puts them at risk. What do we do? How do we do that? What steps do we do? Those are the conditions and the steps we'll begin to really talk about so that we can begin to preserve our community, preserve our kidneys, live healthy, and live well. Thank you.
Excellent, excellent. Let me do this right quick. For halftime, we will reintroduce ourselves. And then I know that we have several hands up, Dr. Anderson, Dr. Court, as well as Dr. Sprott. But first, I'd like everybody to reintroduce themselves, and we'll set the stage again and move forward. Dr. Anderson, please.
Yes, hi everyone. I'm Patrick Anderson. I'm a board certified gynecologic oncologist. I work in the RWJ Barnabas system. Work in conjunction with just about everyone on this panel. They've either practiced with me in some kind of way or has influenced my growth in many, many ways. And I'm so appreciative of being part of this illustrious group. I'm so glad to be here. Thank you.
All righty. Dr. Court, please.
Well, good afternoon. Dr. James Court, internal medicine. I practice in East Orange. And I work with most of these gentlemen here.
Dr. Sprott.
Kenny Sprott, board certified pediatrician, specialized in pediatric critical care and general pediatrics.
All righty. And Dr. Simon.
Hi, everyone. Dr. Segdon Simon, board certified nephrologist. I practice at Newark Beth Israel and Army Medical Center and some surrounding hospitals. Thank you.
All righty. Dr. Atherley.
Good afternoon, everyone. I'm Trevor Atherley. I'm a board certified cardiologist. My practice is predominantly at Newark Beth Israel Medical Center.
All righty. Dr. Aluya, you're on mute.
Yes, thank you. Again, Nelson Aluya, Chief Medical Officer at Newark Community Health Center. It's a pleasure to be here and very happy to be among very esteemed individuals with great knowledge. Like I proudly say, if you put our combined years in practice, for everybody, it's over almost 300 years in practice. And that's a whole lot of knowledge out here. and nowhere else have I seen a group of Black doctors who come together and do this unfailingly every second Saturday of the month. And we've been doing it for years. I commend you and I thank you and I respect each and every one of you for the commitment and the service you provide. Thank you.
Well, thank you, brother, for coming in and joining the group. Dr. Clark.
Hi, good afternoon. I'm Dr. Kevin Clark. I'm a surgical oncologist. I work with pretty much everybody on the panel here. I work at Newark Beth Israel.
All righty, thank you. And Dr. Lawrence Daniels. And Dr. Daniels, I want to say, we got to get you involved with this conversation. I know that kidney disease affects you and what you do. Tell us what you do, Doc.
So yeah, I'm a neurosurgeon. I'm medical director of neurosurgery at Jersey Shore University Medical Center. And you know, kidney disease, you know, affects what I do a little bit when we talk about maybe the pituitary gland. It's more of an issue when you have somebody with chronic kidney disease and they require any surgical intervention, especially brain surgery. It tends to affect their ability to form clots and stop themselves from bleeding, and it makes it extremely difficult to take care of these people from a technical perspective as a surgeon.
Excellent, excellent. And
Another reason to maintain your kidney function and avoid being put on dialysis.
All right, excellent. But we're gonna get more in detail with that. I'm Dr. Omar Bey, pulmonary critical care, a subspecialty in nutrition. All righty, and just let me say, as Dr. Aluya stated, our webinar is every second Saturday at 1 o'clock. Understand that it is Eastern Standard Time, and we invite everyone to let family, friends, church members know. It takes a community to truly educate our population about health. Okay.
Did Jordan get to speak?
Oh, he sure may. I didn't see him there. I'm sorry, Jordan. Let me cut mine short. And Dr. Jordan Garrison, can you please? Oh, he clicked off.
Hey guys, that's a rarity that I don't get to speak.
Can you hear me, Jordan?
Yes, I can. Can you hear me?
Speak up.
Sorry.
Speak up. We lost you, Jordan. I know you're driving and you want to join in. Can you speak up?
We'll get to it later. We'll get to it later.
Okay, you come back. Oh, there you go.
Okay, I'm Jordan Garrison. I'm board certified general vascular surgeon, and
He's on pause.
Yeah, I know he's driving. He must be in a low area there. So we'll come back to Jordan. All right. But what I was saying is the most important thing that I can say about our webinar is please don't change any aspect of your medical care until you consult your physician. Only your personal doctor can truly best take care of your medical problems. Also, I would like to thank OBHealthy for allowing us to use their platform so we can bring this webinar to you. And please go on YouTube, go on OBHealthy's website, obhealthy.com, scroll to the bottom of the page and connect with the YouTube YouTube channel signature, and you will be able to view all of our webinars and so many topics that I think is so interesting. And please do, for education and educating our patients and our people is so important. Thank you. Let's get going here. Patrick, you're next.
Yes. So one of the things I wanted to just mention, I had asked Dr. Simon about some of the common diseases, some of which chronic, some mostly sometimes acute, that affect the kidney. And we talk about the common ones: hypertension, diabetes, collagen vascular, and some inflammatory processes. But a lot of times when I collaborate with Dr. Atherley and Dr. Simon is in patients with advanced cancers. And if Dr. Simon could talk about how some of these advanced cancers can influence the kidney and oftentimes, get in the way of active management in patients with some of these cancers.
Thank you, Dr. Anderson. And this is a really big and somewhat emerging aspect of kidney care lately, partly because of some new oncologic agents that are now available. And like we say, everything we put in our mouth somehow has to be acted upon by the kidney, one way or the other, either in terms of activating it or eliminating it, the waste product that comes from it. So there are certain malignancies or cancers, that do directly cause kidney problem. We do know that a lot of solid organ cancers, like breast cancer, colon cancer, they preferentially cause what we call nephrotic syndrome with the kidney. They have the ability to have the kidney lose that filtering capacity, and it begins to lose a lot of protein and albumin, like Dr. Sprout mentioned earlier. And once your kidney begins to lose protein and in large quantities, it's gonna run into trouble. If I said it was running before, now it's really sprinting. And depending on the amount of protein it's losing, the higher the sprinting and the more likely it's gonna slow down later on. Now that's for solid cancers. Also, we have some cancers that may be closely associated in terms of location where the kidney is. And a lot of the collaborations I've had with Dr. Anderson relates to the type of cancers he manages. So gyne-oncological cancer. So we're talking about cervical cancer, uterine cancer, ovarian cancers, and a lot of these cancers are somehow in proximity to where the kidney is located. And most often, once this cancer begins to grow and get bigger and they start to spread to surrounding lymph nodes, they interfere with the functioning of the kidney. They can directly block the tube, the conduit, which urine flows from the kidney down to the bladder, or they can block even the bladder as well, the ability to be able to urinate. And so this leads to a lot of pressure generated that gets backed up into the kidney, and your kidneys get swollen, and it begins to lose its function. There are also a lot of issues with the medications that I use for treating cancer, and those also can affect the kidney in different ways. They can cause inflammatory reactions within the kidney and shuts the kidney down. The good thing with this is some of these are very dose dependent or medication dependent. So once you stop it or you cut down the dose, then the kidney has the ability to sort of regain its function. Those are not chronic kidney diseases per se, and those we will call acute. We call them acute because there's, sudden things happening within the body that are then causing a quick shutdown of the kidney, and the kidney can stay sleepy in that state for a number of days, weeks. We've shared a lot of patients who even have had to go on dialysis temporarily because they got a chemo agent and somehow it shuts down the kidney temporarily. And oftentimes, the kidneys wake up again. And we sort of work together and we adjust. We say, oh, maybe try a new agent or maybe cut down the dose to the level that the kidneys can handle. So there's a lot of interactions between cancers and the kidney. It's not anywhere near how we see diabetes and kidney disease, for instance, but those are certainly very important as well.
All right.
And if I might add quickly, one of the important aspects of the kidney function in cancer treatment is oftentimes the metabolite or the byproducts of some of the agents we use to treat cancer is excreted by the kidney. So if the kidneys are not functioning because they have a baseline dysfunction or they develop some acute dysfunction during treatment, we now have to adjust the dose of the medication, because then these patients are exposed to a higher rate of side effects, such as lower blood cell count, sometimes added toxicity to the kidney, things like inflammation on the mucous membranes, as in the lining of the mouth, the lining of the gut, and the side effects from some of these agents can be exacerbated if the kidney is not functioning well.
Excellent.
Sure.
Dr. Kaur, you're next.
Yes, okay. I guess I'm one of those who contributed to these 400 years of medical practice, because I recently celebrated myself and Dr. Cunningham. When we graduated, it was May 10th, 1980. However, be that as it may, my question is, Dr. Simon said, in addition to strep, which usually comes from a throat infection, that you can also get glomerulonephritis from the skin. Well, what type of organism would that be? Because generally you'll think of staph, but not strep on the skin.
No, it's
Yeah.
strep again.
It's strep again.
Strep, it's group A strep that's responsible for impetigo. And actually, that's more commonly associated with glomerulonephritis than the group A strep in the throat. But these are infections that are not found either in the heart or in the kidney. It's an antibody or autoimmune sort of a system that's in play.
Also,
Now, once the heart valve is damaged, then you can have an actual infection on the damaged heart valve. But usually with rheumatic heart disease, it's thought to be an interplay, and it might be genetic for some individuals that get the damage when they have are in the recovery phase of the strep infection.
also, this new gene that's been out there, in my opinion, what causes most of the problem is patient neglect, because they don't follow up their kidney function. They don't come for follow-up. They don't get it checked. You can have, say the gene plays a role, but if patients don't cooperate by coming to get the testing, the reason most of them don't come is because, one, they're not in pain. They're not in pain, they're not sick. How do we help the world overcome this neglect that patients do in terms of sickness equals pain? No pain, no sick.
Can I ask a quick question? So it's, you guys may or may not have addressed this earlier. So hypertension and diabetes are probably 1 and 2 or 2 and 1 in terms of the causes of chronic kidney disease. Is it preventable, or you can manage it? So can you prevent the onset of kidney disease? And if you can prevent it, how do you do it? If you can't prevent it, how do you manage it so that you don't eventually go on to dialysis? Right. Or is it just a slow progress, and over time you will eventually end up on dialysis?
I think Dr. Simon said it's almost inevitable, especially if you have diabetes. Together with high blood pressure, it's almost inevitable that you may develop kidney disease later on.
So with that being said, the guidelines for patients to be transplanted, and again, I may be repeating some of the stuff. I'm sorry, I joined later on.
No, go ahead, Kev.
But should those patients be offered transplants earlier than the average?
Yes, I'm sorry, Dr. Court, you want to go before?
Yes. I have to say that in my practice, I've only had one patient who had group strep that damaged her kidneys, and I encouraged her for so many years to go on dialysis. She's to go off dialysis and get a transplant. She said no, and she subsequently left us about 2 or 3 years ago. And this first happened around maybe 1983 or 1984, but she survived on dialysis for several years.
If I may add something to that.
Go ahead,
Just one patient.
Dr. Simon, I'm sure you're gonna come on. That one of the things everybody here ought to have a doctor, whether you're a doctor or you're not. We all have to have a doctor, and at least once a year you need to go see your doctor. Period. I mean, we drive cars every day, and for some of us, until the car would start making a noise or start, doing something, we don't go. But then we have smart cars these days that will tell you have 200 miles to oil change. You have, it'll tell you, and it'll give you signs and if anything. So we do take our cars for servicing and checkup. If we do that, why can't we take ourselves for checkup? It's once a year. So that once a year is when you sit with your doctor, they run this test where they check your kidneys, your blood levels, your everything that you need to do, including the kidney function, because those things are really important. And if you're on medications, they tell you if the kidneys are affected with those meds, if the liver is affected with those meds. You understand? And then you'll be able to explain some of the other stuff as well. And that's the time where you'll be able to, because at those visits, it's not the 15 minutes visit anymore. We need to understand some same things. If you go see a doctor and it's not an annual check, it's a 15 minutes visit. And that's why we complain, oh, the doctor didn't spend enough time with us. Yes, because the insurance company has 15 minutes to spend with you. But if you set a time where it's an annual well visit, which the insurance company will pay for, it's 30 minutes.
Yes.
And that's a lot of time where you can sit back and discuss with your doctor, because a lot of us don't know that. Now, before you go see a doctor, I always tell people it's like going to church. You have to get prepared. You dress well, nice well, put on some good clothes, and then document the things you have in your mind that you want to discuss, so that it's focused, it's direct, and the provider will spend that 30 minutes. You can time it. They can spend that 30 because you earn it. It's legally yours. And you can sit down and discuss. Now, once you're done, they can also talk about your family history and risk of cancer. Cancer is ravaging our communities. We talked about solid cancers and non-solid cancers that are affecting our people. And these are the certain cancers that are affecting us as Black people than other people. The diabetes and the risk. We talked about that already. It's a time when you'll be able to sit down and say, Doc, do I have diabetes or not? If you don't, do I have pre-diabetes? You know what your diabetes status is. And I've always said it here multiple times. Everybody needs to know what your diabetes status is. Either you're pre, you have no diabetes, you're pre, or you're diabetic. So that you can, at that point in time, have a discussion with your doctor and say, you know what, what steps should I take to do this? And your blood pressure as well. So as you do that, and you ask you to go do the blood work, then guess what? One of the things we also must do as well is have a follow-up with your doctor to discuss your results. We think, oh, once we do the blood work, we're gone. The doctor will call me. Yeah, the doctor has 3 days to call you and within a week to call you for normal results. But guess what? The onus is upon us as an individual to set up a follow-up visit, and I always advise 2 weeks after the visit. 2 weeks, you set up a follow-up visit so that you can sit with the doctor. Then they can spend 15 minutes at that time discussing your results. And then you decide and know what steps to take subsequently. Now, as a
one of the
primary care
questions-
doctor, once you see somebody who has chronic kidney disease, guess what? The question is this, Doc, when do I begin to see a nephrologist? Because one of the biggest issues that's happening in our community is this. Our patients are going or people of color are going to see Dr. Simon and his colleagues too late. Too late. And by the time they get there, it's almost like there's nothing for them to do. By core principle, you need to refer somebody to go see a kidney doctor when you're stage 3, and preferably stage 3A. That's when you begin to refer somebody. As a matter of fact, earlier, if you can. Now, some people say, oh, you begin to plan for dialysis when you get to stage 3B or stage 4. But that's a different story. But as an individual, we need to do that, because we've talked about here again, and now before I end up, when we look at our blood results, the American Nephrology Society and the other society, they begin to talk about what it is they need to do to help reduce the disparity in kidney care. Why are they saying that? Because they came down to a point where they begin to break the kidney function rate, the GFR, as you know, where they separate African Americans and non-African Americans. You see that when you do your results. Now, what does that mean to us? I'm sure Dr. Simon will talk to us about that. Why are they separating it? What's the implication for us as Black people? Because I'm a physician, but guess what? I'm also an individual and I can be somebody's patient. What does that mean to me? Is it good or is it bad? And if they take that off, what's the outcome for me as well? So those are discussions we must begin to also accept as we, go on and talking, with kidney and kidney disease that we talk. I'm sure we'll talk about the kidney disease with regards to diabetes exclusively and hypertension, because those are the number 1 and number 2 cause of kidney failure in the world.
Right, thank you. Thank you very much. Excellent coverage. Dr. Sprout, you've had your hand up and you've been patient. Then we got Dr. Court and then Dr. Atherley.
Mine will be quick.
But, understand we have a couple questions too that I definitely want to connect with these questions before we finish. We only have a half an hour left. Dr. Sprout, go ahead.
Yeah, just to touch a little bit about what maybe people are concerned about when they're talking about medications and kidney failure, or when the kidney is starting to become bad. You know, we talked about creatinine being a protein that's in muscle, and when that creatinine, which is a function of your muscle mass, hits the kidney, if it's filtered, it's excreted. And so the amount of creatinine that's being produced in most people is a small amount every day. But if it's not being filtered, then it starts to rise in the blood. And that's a signal that the kidney isn't functioning normal and maybe in the process of failing. The other aspect we talked about is the kidney getting rid of toxins. And some of these toxins we think about are bad, but you know, lots of medications can be toxic. And lots of medications are cleared from the body via the kidney. And so you can imagine that if your kidney function is starting to go bad and your creatinine goes up, then the medications that are cleared by the kidney aren't going to be cleared as fast. And Patrick talked about that a bit when he talked about some of the chemotherapeutic medications, but lots of medications, including heart medications and antibiotics. And lots of drugs are cleared or gotten rid of from the body via the kidney. And if the kidney is not getting rid of them as quickly, they can build up. And some of these medications can be toxic to the kidney. Some of the antibiotics, the gentamicin and all. And I remember when we had kids that we treated that had acute renal failure, we could give them one shot of an antibiotic that might last for 3 weeks because it would stay in a therapeutic level. And so people need to be concerned, and their doctors, and Dr. Aluya, you talked about when they ought to get referred. You know, the issue is as the primary care doctors start to do these tests and they start to pay attention to the GFR and the creatinines, they are the ones that are be making the referrals. The patients aren't going to know if they're 1, 2, 3, 4, 5, 6, 7, or whatever those various classifications are. And so if they start to see early on the annual blood testing that they do that there's an issue, they ought to make the referrals. But I think that individuals that are taking medications, and the primary care doctors ought to be letting them know that these medications are being cleared by the kidney. They need to be making adjustments in the dosage of the medications so that they don't start to build up and possibly cause problems. Not only that, you know, some of these medications are known to be toxic to the kidney. And so if you are taking a medication that is toxic to the kidney, then the doctor ought to make a concern about reducing the amount so that that medication may not damage the kidney. And just one last thing, and again, I'd be interested to hear, you know, I said earlier that when you ingest things, food, fats, carbohydrates, they're metabolized into CO2 and water. But the one thing that has to be gotten rid of by the kidney are proteins. And there's been some thoughts that the amount of protein that you take over time may have a deleterious effect on the kidney. And so one of the questions I have is, if you see someone that might be having some issues in terms of a rising creatinine or a decreasing kidney function, might it be of any benefit for the physician to talk about reducing the amount of protein intake? Because certainly if the kidney's got to get rid of the protein and you don't have as much protein, then maybe you don't have as much work that the kidney does. But I'd be curious to know whether or not there's any interest in altering the diet. And I know Patrick's big on diets in terms of reducing the amount of protein intake in an individual that may have a predilection to have issues related to their kidneys.
Yeah. That's a good question. Dr. Simon is, I think he stepped away just for a minute. So as far as proteins are concerned, I know that, you know, as far as when you're feeding a patient, giving them either nutrition via the IV route, I know we worry about proteins and to assess whether the proteins are being utilized appropriately to make muscle or because our proteins are what we call it preserving our lean body mass. And those proteins are either utilized, and when they're utilized, they're broken down, and then you have the nitrogen, as you spoke about earlier, Dr. Sprott. I know we assess that, but as far as loss of proteins through the kidney, I mean, there are many things that I think Dr. Simon would have to answer as far as that concern. Maybe someone else could give us a
So
little
Omar,
more
just
information.
in terms of that, you know, when we're treating individuals whose kidneys are shut down, and hopefully in pediatrics, they recover. What
Right.
we do is we absolutely limit the amount of protein that they take, because that buildup of the breakdown product of protein, that BUN, blood urea nitrogen, can
Right.
cause damage to the brain. And so we limit it. And the same thing goes if you're looking at the function of how often someone needs to get dialysis. If you reduce the amount of protein intake that they are eating when they're on dialysis, the less protein they take in, then the less the buildup of BUN, and the less the need to actually get rid of BUN. So, but my question was whether or not there's any belief that the amount of protein that you take in, if you reduce it, it might decrease your potential to develop problems with the kidney.
Yeah.
If I might comment, you know, the physiology eludes me right now in terms of specifics, but in general terms, Dr. Sprott is right. If you look at the renal diet, when we order a diet for a patient with kidney disease in the hospital, there's a specific renal diet, and oftentimes it has reduced protein and also reduction in certain electrolytes such as sodium and magnesium. So you're absolutely right. The amount of protein in patients with kidney disease needs to be adjusted. Whether or not the adjustment slows the progression of kidney disease, I would lean on Dr. Simon to comment on that aspect of it.
Yeah, I agree with you, Patrick. You know, and as far as the kidneys are concerned, and as far as electrolytes, we're talking about potassium, phosphorus, sodium. There's so many electrolytes that the kidney helps regulate, number one, especially with feeding. And you're talking about also giving patients feedings via, I would say, NG tube feedings, or feedings that through a tube to the stomach. There are certain formulas that we give that are kidney specific, because if the kidney is not working appropriately, then those elements the body cannot handle appropriately.
And then there's what, you know,
but I grant with you whether large amounts of protein will hurt the kidney over a period of time or will progress kidney disease. I can't answer that. And if
then there's
Dr.
one of
Simon, hopefully he'll come back on with us and he can answer.
One of the
he said he
intrinsic
might not
problems.
be able to return at one point. Maybe he's coming back now.
There's one of the intrinsic problem that sometimes either through direct toxicity or an inflammatory reaction is when we have ischemia or tissue that's devoid of blood supply and you have muscle necrosis or muscle breakdown, you get this muscle protein myelin in the bloodstream. And either via a direct toxic mechanism or just increased protein load to the kidney, we see patients with myelinolysis oftentimes go into renal failure. And you know, so I can't explain whether it's related to, like I say, an immune response, an inflammatory response, or just an increase in the intravascular protein load that the kidney has to encounter.
Right. Good question. Dr. Simon is back with us. I see you're driving, and that's great.
Yes, I'm so sorry, but I'm parked right now. I just had to quickly drop my son off at the soccer game. So I'm at the parking lot, so we're good.
There was a question, Dr. Simon,
Yes.
whether increased protein being delivered to the kidney would progress or increase the possibilities of kidney failure.
Okay. Yeah, that's an interesting question. So there is a very close relationship between the kidney and nitrogen balance. And when we talk about nitrogen, that's basically about our protein intake. So the way it works is the more protein we eat, the more work we give our kidneys to do. Because when we talk about the main function of the kidney, that's maintaining acid-base balance. Now, there are different kinds of acid that we generate on a daily basis. So there is two main ones, the organic acid and the inorganic acid. So the organic acids are like our CO2 that we produce from carbohydrate metabolism, all the components of the, sorry to use this phrase, TCA cycle. So those acids, we call them organic because the body can reuse them whenever the condition is favorable. So if blood pressure is good, there's adequate oxygenation, the body can reuse this kind of acid, like pyruvic acid, lactic acid, and stuff like that. So we don't typically need the kidney a lot to handle those kind of acid, unless if the body is in shock and there's not good perfusion going on.
Mhm.
So those organic acid don't cause any major trouble. The inorganic acid, which are primarily from protein source, and especially animal protein, are the ones that there is no way the body can get rid of it except through the kidneys.
Mm.
And now, so when we talk about renal diet and we say cut down on protein intake, that's just because we are trying to decrease the amount of workload the kidney has to do on a daily basis. Because those inorganic acid that is generated from all of these animal protein sources, they have to be titrated. So because they are called titratable acid, the kidney has to essentially generate a base to counteract that acid. So the more of it you have, the more your kidney has to do. So, and if you're overworking your kidney constantly with a lot of animal protein exposure, then the more work it has to do. And over time, theoretically, you can say, well, this kidney may get tired later just because of the workload it has been exposed to. Now, this was extrapolated from review of people who are largely vegetarian, or those who follow vegetarian diet with very minimal animal protein exposure. They tend to have lower incidence of chronic kidney disease because we think their kidney hasn't had to do a lot of work over time, and so it just lasts longer. And that's why also when people have significant chronic kidney disease, we give them this advice, lower your animal protein intake, because you're just trying to decrease your inorganic acid sources so your kidneys don't have to do too much extra to get rid of those acids. So that's about with protein load and kidney disease. But I would just want to touch on a few things that were mentioned earlier before I give the space. The gene, the APOL1 gene, it's important because I think it's going to change the field later, but I'm talking about distant future because right now there's a lot we know, but there's a whole lot to be known about it. We know it's primarily in the African American ancestry, and people that have it have a higher incidence of accelerated kidney damage. They have higher risk of hypertension and resistant hypertension, very difficult to control. And those people over time, somehow it promotes FSG, that's focused sclerosing glomerulonephritis, for those who are medically inclined. For those who are not, just means it promotes a lot of scarring to happen in the kidney for some weird unknown reason. I think that over time, where the research will go would be, because as of right now, they can test to see if you carry the gene or not, but we don't have a plan B. So if you carry it, then so what? So, well, you still have to do everything we've been saying. Follow your doctors closely, every year or at least twice a year, make sure you get your kidneys checked. Make sure if you have high blood pressure, you control it very well, because those are the general things we tell people. Avoid medications that are bad for kidneys, the ibuprofen, the Motrin, Aleve, those class of medications we call the non-steroidal anti-inflammatory drugs, because those together with this gene, if you have it, you increase your risk of developing kidney damage. Maybe over time, it could become something like a sickle cell list now when we get the full detailed analysis of this gene, its transmissibility. We know it's genetically inherited, but are they like, how are the alleles transmitted? Can you have like a carrier state? How is the penetrance? Do we have to now do marital counseling and say, hey, if you have a carrier, don't marry someone else that also carries the gene, so that way you're less likely to produce an offspring that will have the full-blown, genetic abnormality. So all of these are probably still being explored at the moment. But we do know there is a very close association. If you carry that gene and you're likely to pass it on, and it's the incidence of kidney disease among that cluster of family is much higher. So they need to pay more attention. Some other questions that have been raised is Dr. Aluya mentioned the only goal, and Dr. Clark rather, how do we prevent this? Can we prevent it? The only way is education. People need to know that what kidney disease is about, how it's developed, because we cannot wait for when symptoms start. Unlike some food poisoning, you eat 3 hours ago and then all of a sudden you have pain, you're throwing up, and then you have food poisoning, easy. With the kidneys, it doesn't work that way. With the stages that Dr. Aliyan mentioned, from stage 1 all through to 5, most people can get up to stage 5, which is end stage renal disease. We're talking technically you need dialysis now without yet having any symptoms. And now that is the scary part of kidney disease. And because our people are not so inclined to seek medical attention, one of the panelists says pain equals seek help. Well, in kidney disease, we're saying that's not the case. You just have to go check it, because you're not going to experience anything until it is way too late. So the symptoms develop very late, and most often than not at that stage, there's very little anyone can do, because once the damage is done, you can imagine if you have a lot of scars in your kidney, we call it sclerosis, even because I see some people, they have a kidney function that's so poor, say 10%. And I say, have you seen a doctor before? And they say, oh yeah, 2 years ago, I saw a doctor in Florida. Then we call Florida, we get their lab, and we realize their kidney was 67% 2 years ago. And today you're 10%. I said, that's too drastic. So let's biopsy the kidney. And then we go ahead, we do all these tests, and the biopsy comes and says, hey, we just have scars all around your kidney. And you cannot treat a scar. So once the damage is done, it's irreversible for the most part. So education is the key. Early referral from our primary care guys. If you don't wait until the GFR is less than 30, or preferably as you're hitting below 60, you're sending them out to a nephrologist. Have that nephrologist begin to educate them, begin to tell them how to care for their kidney to at least decrease, the slope of decline in their kidney function. One more thing someone mentioned is about the GFR and how it is calculated, and the difference between African American and Caucasian. Thank goodness, we've been able to win that fight. I say we because the colored people, the African American population, when the GFR was first introduced into clinical practice, and your lab started to carry it, you will see 2 different GFR. You see one for African American and one for Caucasian. Now, the GFR is calculated based on the serum creatinine, your body weight, and other factors. So they came out with those two calculations, which gives an African American person a higher level of GFR for the same level of creatinine compared to a non-African American person. So over the years, we continue to study this formula and the calculus that was used, and people realize that, you know, whether deliberate or not, I know this is a public event, so I want to mind how I say this. The previous way it was calculated placed African American at a significant disadvantage when it comes to receiving care for their kidney. Because if your serum creatinine is 2.5, it says your GFR, for instance, is 50%, and you feel like, oh, 50% is great. So it's not that bad. But a non-African American with a serum creatinine of 2.5 say, hey, your GFR is 20, and all of a sudden the panic mode sets in, they get you to see all the specialists, you get listed for kidney transplant, and then we realize that non-African Americans, AKA Caucasian, are getting kidney transplant way earlier than the counterpart, that's African American, for the same level of serum creatinine because of this GFR calculation they introduced. So this was fought by a lot of nephrologists in the community, African American community, through the KDIGO and all those channels. And now, as of the last 2 years, also I think 3, that whole formula has been thrown out. So if your lab is still showing results of EGFR African American and non-African American, that lab is not up to date. You should stop using that lab, or you should call them and have them update their lab. All your serum chemistry right now should come with just one GFR, whether your patient is African American or not, because this has been shown to now increase the access to kidney care that the African American community has been lacking throughout those years that we were using those different GFR calculations. And just as an example, one of my patients was called in last night, 2 a.m., to receive a kidney transplant at St. Barnabas. He's there right now. Okay, and this was after this law was passed, that this GFR no longer holds. I was able to dig out his lab from 2019 that shows that his serum creatinine at the time was about 3.5, and his GFR should have been 19, which will have qualified him to be listed for kidney transplant. But because he was African American, his GFR came up reading 28, and based on that, he was not qualified to be listed. So once this law changed among the transplant listing, I sent in those labs and say, hey, this is 2019. So automatically they backdated his wait list that started instead of last year to 2019. And all of a sudden he shot up the list. We only did this like last month. And now tonight, this morning he's at Barnabas about to get transplanted. So we've been at significant disadvantage, African-American among, I don't know, I'm talking from just what I know among, as for kidney care. I'm sure this happens in every other specialty as well. So we need to continue to be on the lookout and continue to especially position ourselves on the table where policies are made and question those policies, and honestly how they arrive at those policies, because sometimes a lot of things are done that puts us at disadvantage. We have the higher population of people with kidney damage, but yet access to getting the care was so bad. Now they're trying to make up for it, but oftentimes it is always too late. So I don't know if I remember any other questions that have been asked.
One quick question I'd like to ask, certainly in terms of the patient-oriented type of concept, When patients come to us, we like to know that they're following instructions appropriately, even if they're measurable results. And so the patients can commend it on these. It is somewhat difficult to advise a patient that control of the diabetes, as evidenced by good control of the hemoglobin, A1C, and the blood glucose, still may be associated with continued progression of disease to cause kidney failure. Do you have any answer in terms of how we can further look and select those patients who might be at greater risk? And my second question relates to cholesterol. Cholesterol, in terms of its ubiquitous involvement and involvement of the entire body, is there any specific renal involvement with hypercholesterolemia, excess cholesterol intake, or excess levels in the bloodstream? What do we tell our patients?
Yeah, so as for the first part of your question, I always tell the patient, you have diabetes. Hey, you're gonna have kidney disease down the road if you live long enough, no question. But that's not your take-home message today. Your take-home message today is, if I control my diabetes very well, then the severity of this kidney damage and the onset of it, I can influence. So you can delay when you get it and how severe it is. And I think it's this second arm that we need to emphasize. And sometimes when we spend time with the patients explaining this part to them, then they get it. Well, there will be some who says, well, you say I'm going to have the damage anyway, so I don't care. Let me just enjoy my life. Well, oftentimes you will get some of those, but what can we do? We just continue to educate. And now the second part, when it comes to cholesterol and the kidney, there's been extensive studies on those. Dr. Atherley, you probably will be aware of majority of them, because a lot of the studies are done in conjunction with cardiology studies. For ESRD, the lipid lowering agent, statins, did not offer any mortality benefit for our patients. That if you're already on dialysis. And I think one of the reasons, I don't know if it's proven or not, but at least the theoretical reasons for this is because a lot of the cardiovascular death, that's heart-related death associated with end-stage renal disease patients, is not really due to obstructive coronary artery disease. It is more of a volume-related issue, LVH, and with the heart, and cardiac remodeling, and also electrolyte and arrhythmias. So I think it wasn't so surprising that statins did not make any benefit if you're already on dialysis. However, if you have CKD, and we're talking stage 3 and 4, those are significant CKD, 3B and 4, moderate to severe and severe. We do encourage the people to be on cholesterol medications. If they're already on it, we continue. If they're not on it and they have hyperlipidemia per the guideline of general population, you can start them on it. That's, I think, where the studies stand when it comes to cholesterol and chronic kidney disease.
All right.
In ESRD, if they're not already on statins, you won't change their mortality. In CKD, you probably will, and we encourage that.
All right, CKD is,
Chronic kidney disease.
thank you. All righty. All righty, Dr. Court, we're going to, you had a question?
Just a comment, just a comment, and Dr. Simon answered my question in terms of the labs. There's one that does report one value only, and there's, I think the other one still reports a separate value for African Americans.
Right.
It should be just one value from
one value.
It should be just one value now. Yes.
it should be just
As of last year.
yes.
All right.
Yes.
Dr. Anderson.
Yes, with respect to diet, again, we talk about protein and certain electrolytes in kidney disease. Dr. Simon, can you comment on, one, the causes of renal stones and how diet influences the formation of kidney stones?
Thank you, Dr. Anderson. So there are different kinds of kidney stones, as we can imagine, but the vast majority of them have calcium implicated in stone formation. Now, I always like people to underline the word when we say calcium, calcium where? Calcium in the urine. Well, if you have a lot of calcium in blood, you can then infer that the kidneys will filter more calcium. And so you will have more calcium in the urine and more likely to form calcium-based stones. When we talk about stones and calcium-based stones in the kidney, we look at factors that influence them. Factors that promote stone formation and factors that inhibit stones formation. So when it comes to diet, it's a little bit tricky to give an overall approach, because first we try to know what kind of stone someone is forming, and then we approach it individually. There is a broad way to prevent stone formation. One, you hydrate very well, because if you make more urine, you're decreasing the concentration of the chemicals, the calcium-related chemicals that's forming the stone. So you're less likely to form stone. Two, we say decrease your sodium intake. I don't like to use the word salt in my office, because when I say cut out salt, people say, oh yeah, sure, I don't eat salt. But they have all this seasoning, Maggi, cube, and all kinds of seasoning, and they just double up on it to make the food taste just as sweet. But all those seasonings come with sodium. So they say, doctor, I don't eat salt, but then you have edema, your pressure is through the roof. Then when you look at their cupboard, I've had people send me pictures from their kitchen just to see their seasoning, and you'll be surprised to see. So sodium is closely linked with stone formation as well, because of how the nephrons, the part of the kidney handle sodium that's within the urine to be formed. If you have a lot of sodium in the urine, for some reason, it affects how the kidneys handle calcium reabsorption, and that can lead to more calcium within the urine, and then you'll be more likely to have stones. So lowering sodium, increasing fluid, and avoiding carbonated beverages, because all of those beverages like your Coke and so on, they have they are a good source of some chemicals that can also encourage stone formation. Now, I don't know how to explain it, but as funny as this may sound, there are certain people who have certain stone and we treat them with calcium. Now, if you've had bariatric surgery, like weight loss surgery, and to try to lose weight, or you've had extensive intestinal surgery for whatever reason, the way your body handles bile, the bile salt can change because of this surgery. And so you may begin to make a lot of what we call oxalate within the GI system. That's within your gastrointestinal system. Now, the commonest type of stone is calcium oxalate. We also have other calcium-based stone, calcium phosphate and all, but calcium oxalate is the commonest. So if you have a lot of calcium or you have a lot of oxalate in your urine, you will make stone. So for this peculiar kind of patients that have had gastric bypass or intestinal surgery, or for whatever reason, they're just maybe genetic reasons, they are making a lot of oxalate within their gastrointestinal system, we try to give them calcium. That's because the calcium orally, when taken by mouth, we bind this oxalate in the gastrointestinal system. So you poop it out, and the oxalate will not get to the urine where it can form stone. So dietary advice for people with stone is a little bit tricky. First, we need to identify what this stone is, and this can be done very easily. There's a test we call litholink analysis. They collect your urine for 24 hours, and then they analyze it. They analyze all the chemicals within the urine. And based on those analyses, we can tell you these are the kind of stone you're more likely to form. And then we tailor our advice, both dietary and even medication, to that particular stone.
Excellent.
I hope that helps.
I'm just going to let you know that it's 3 o'clock, and we're going to go over just a little bit if everyone doesn't mind, so we can get all the questions answered. Dr. Kendall Sprout, you're next.
Yeah, you mentioned the issue of the relationship between the GFR, the norms for Blacks, and how that's kind of been eliminated. But, you know, Dr. Luya indicated the number of African Americans that are in renal failure, those that are on dialysis, and the issue of transplantation. And my question is related to the ability of African Americans who may have renal failure to get on the transplant list in the first place, and the relationship between the number of African American nephrologists versus non-African American nephrologists, and whether or not there's an influence in terms of the ability of the patients to get diagnosed and to get on wait lists.
Yes. So access to care is just one big topic when it comes to kidney and transplantation. We don't have near enough African American nephrologists as we will expect. Our patients sometimes.
So you said, as you can expect, when you say, is there an expectation about the ratio between nephrologists and the population in general?
Yeah, so like Dr. Aluya pointed out, if 34% of dialysis patients are African American, and we only constitute 15% of the population, but if you look at our ratio of nephrologists, African American to a patient, it's sky high. So we don't have enough African American nephrologists who I believe will provide better care for their population. And we don't have that. That's one arm. Another arm is just education. And sometimes I don't want to use the insight that some of our patients have is just not quite there. And there's a lot of layers to this. I've seen a lot of educated Black patients, well informed in other areas. And when we start to talk about health and the kidney, their level of trust in the system is not there. They will still rather buy a GNC product that says this helps the kidney and that helps the kidney, rather than take lisinopril for their blood pressure. So it is just a multi-layered problem. And I think the only way through it is really just continue education, try to show people more, this is what's going on, this is what you can have. And I think it's getting better, but we still have a long way to go.
Excellent, excellent. Dr. Aluya, I know you have a question, but in the question box, there is also a question about explain the function of the Novolog. So in your question, great, but could you explain that last viewer's question for us?
Right.
Thank you.
So I'll take the question. Novolog obviously is insulin, and it's a quick action insulin that we use to treat diabetes. And the beautiful thing is insulin, when it came back in the early 20th century, and thank God for that. Otherwise, for those who have type 1 diabetes, it would have been it was death sentence for them until insulin came. And they produce insulin from different means, initially from the gut and cow and then pigs, but now we can synthetically produce insulin from the lab, which is a good thing. It's quick acting. It's you have to watch your sugar, because otherwise you drop your sugar so quickly. And often enough, we tell people, look, before you take your insulin, just put your food ready, especially the short acting one, Novolog. Now you have the long acting one, like the Lantus and Adamol, Log, and the other ones, which will work the whole day. The short acting one, make sure you have food ready before you eat, before you take it. So when you eat and then you take it, it works immediately. So that's basically what it is. Now, when it comes to the issue of the kidney, and I'll leave the question to Dr. Simon eventually. Two things. One, We have seen a whole lot, and I've seen a whole lot of people, especially women, when we talk of genetics and anthropology with kidney disease and stone formation and all that. I've noticed a whole lot of women, predominantly African American women or people of African descent, who've had more oxalate stones than usual. And I've always wondered why. And it runs in some families. I guess there's some genetic predisposition to that, where either they absorb too much of the oxalates in their system. And when I ask those questions, they always tell me, oh, I eat a lot of spinach. So spinach has a whole lot of oxalate in it. So if you see a lot of young women with chronic kidney, with a lot of stones, ask the kind of question, do you eat a lot of spinach? And they'll tell you, yes, we did eat a lot of spinach. So a lot of them, listen, cut that off. We know spinach, cause a lot of oxalates and then stone formation. Now, down to the question and the nitty-gritty of that before we end is this. The issue of the ApoL1 gene, it gives you a 10 times increased risk of you ending up on dialysis if you carry the gene. And the gene is carried in the same format like sickle cell. Meaning if you have, so the APO gene actually, it's actually a gene that codes for certain part of your immune system so that it'll help protect your immune system against diseases. Now, the kind of disease that protects against is the sleeping sickness, the African American type sleeping sickness, which is called trypanosomiasis. Now, just like with the malaria, when the valine, positive and blah, 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 began to change so that it can protect you from malaria, the same thing happened here. So once you have a defect in that APO gene that's supposed to help improve your immune system, that defect, for some reason, begin to affect your kidney. So it increases the rate of which the sclerosis, meaning the clotting and the breakdown of the cells within the kidney, the rate at which it happens goes really fast. And it's 10 times when you have that. So, but a lot of the time, if you carry both genes from your mom and your dad, that's when the risk is so much higher, right? So that's what happens. So the question is this, like you said, Dr. Simon, in the future, are we now going to have genetic counseling with that gene? Is it available for us to screen? Because a lot of us are ending up on dialysis, which we shouldn't be. For those who are Nigerian descent or extracts, we know of a former Senate president who's in jail right now in the United Kingdom because he tried to help his daughter get a kidney transplant. What did the daughter have? They got the guy into the UK to try to get kidney transplant. And then the whole thing, backfired and he's in jail, his wife is in jail, and the doctor is in jail. Now, what kind of kidney did the young daughter, who graduated from college not too long ago, what kind? She has the APO1 gene defect in her kidney that caused her kidney to fail. So you see that these things are translating on a social level in itself. So in the future, are we going to begin to have counseling? Probably yes. Is that the kind of question we begin to ask family members to know what it is? Yes. Now, my question to you, Simon, is this. What is the future? We live in the area of AI, genetics, precision medicine. What is the future of kidney disease in the face of technology and where we are? And I'll close. Thank you.
All righty. What we're going to do is, and Dr. Simon, I understand he's driving and he probably can't get that answer to you, but I think that as we go forward, AI is going to be much more a part of medicine and a part of what we do and how we do it. I would like to, before we end, and we're a few minutes over, so we're going to end it right here, but before we end, I would like to recognize that many people are congratulating Dr. Court, and I think he had to step away because of the congratulations. And this is what someone said. Congratulations, Dr. Court, on your 43 years of dedicated service. I am one who benefits and still continues to do so. Thanks. So, Dr. Court, I know that you had to step away and we will all talk to him in the future, but 43 years, that's commendable, outstanding. And he serves the community. I must admit, he's one of the hardest working doctors that I know. And 43 years it's outstanding. Thank you. Thank you for your service.
Hey, Omar, I just saw another comment that this topic needs to have a session, a part 2 session to it.
I think it does, because the kidney is something, it affects us in so many ways. And I agree, Patrick, and I think this was very, very telling that African Americans in so many ways, I should say people of African descent, in so many ways, we need education as far as our health is concerned. And part of that education is stepping back and accepting that you have to go to your doctor and you have to listen to your doctor, and not go once, but make it a regular yearly occurrence or bi-yearly occurrence, but it has to be there. All
So
right.
Omar, just, I'm always a little bit cynical about things, but
Not really.
Nelson's question, you look at all the money
Mhm.
that's being made off of dialysis.
Yeah.
Off of the backs of African Americans.
Yeah.
I mean, it's huge. You can't go through a Black community and not see almost as many pharmacies around as the dialysis centers.
Units, right.
And so, the people that are making money, and again, people believe that Medicare may go out of business or bankrupt because of the number of people that are on chronic renal failure and dialysis. But as long as these people are making money off of dialysis, I don't see them wanting to make less money. And so there are going to be competing interests in terms of what we are looking at. The people that are millionaires and the number of people that are employed and the amount of money that's going towards the treatment of chronic renal failure is enormous. And so my cynical sense is that we talk about education, we talk about the things and the correlation between diabetes and renal failure, but the amount of money being spent on the treatment of diabetes and the treatment of chronic renal failure is huge. And I'm not so sure that there are interests that are not interested in trying to develop cures or prevention. So I'll leave that alone, but I think that you can't ignore it. If you look at the money, you talk about the number of people, you translate that into the dollars just in this country, it's huge.
True. So true. So true. That's a discussion that we'll definitely have going forward. And Dr. Simon, I thank you for coming on. Dr. Patrick Anderson had made a statement, if you didn't hear, that we may need part 2 to this one, because we continue to have questions, and thank you so much for being so detailed. And I hope that the audience had learned something today, and hopefully when we have part 2, they will attend as well. Let's close here. What I'd like to do is thank OBHealthy for allowing us to use their platform so that we could bring this webinar to you. Understand that it is every second Saturday at 1 o'clock. Please, friends, family, church members, it takes a village. I'll keep saying it, because we need each and every one of us out here to know more about our health. Most importantly, do not change any aspect of your medical care until you consult your physician. Only your personal doctor can appropriately take care of you. And if you want to see any of our webinars, which have a multitude of topics, medical topics, just go to OBHealthy, scroll to the bottom of the page and hit the YouTube sign. Go into our YouTube channel and please subscribe so we can continue to bring these webinars to you. After all of that, I'm going to say thank you very much to each and every one of the physicians that tuned in today and gave their knowledgeable contribution, and also thank you to all of you out in the audience that joined us. We shall see you. Yes, we shall see you in the future. And what I should say is to stay tuned to the OBHealthy website. We will have months of vacation, and note that next month we will not be here because that'll be a vacation month, and we will let you know when we are not on. We won't do the webinars, but next month we will have a vacation month. And thank you, each and every one of you. We will see you in May, June, July. Peace, everyone.
Peace.
Thank you.